Assalamu alaikum friends, welcome to my channel MBBS and BDS lectures. Today I am going to make second video of diabetic emergencies. In first video we already studied diabetic ketoacidosis, but in today video we study two topic: hyperosmolar non-ketotic coma and second is hypoglycemic coma. In third video we will be study diabetic neuropathy and diabetic foot. If you want to watch the same topic, second video of diabetic emergency in Urdu or Hindi, I already upload the same video on my channel. Go and watch that video. But if you are English language viewer, then this video is for you, because today we study in this video in English language. Now first we start from hyperosmolar non-ketotic coma. Topic outline include: number one, difference between diabetic ketoacidosis and hyperosmolar non-ketotic coma. Second is similarities between diabetic ketoacidosis and hyperosmolar non-ketotic coma. The third is definition of hyperosmolar non-ketotic coma. Fourth is pathophysiology. Fifth is investigations. Sixth is clinical feature, and seventh is treatment, and eighth is complications. But first we start from definition, then pathophysiology, then difference, then similarities. This is the sequence. First we start from definition of hyperosmolar non-ketotic coma. Basically, the definition of hyperosmolar non-ketotic coma is that hyperosmolar non-ketotic coma hyperosmolar non-ketotic coma basically occur in type 2 diabetes mellitus, and the basic characteristics of hyperosmolar non-ketotic coma is there is a seriously increased osmolarity of blood. There is a serious increase osmolarity of blood, but ketone body is absent here. What is definition? Hyperosmolar non-ketotic coma is a diabetic coma in which blood osmolarity becomes seriously increased. Not only increase, seriously increase, and occur in type 2 diabetes mellitus, and ketone body is absent. There are three things in definition. Number one, there is a seriously increased osmolarity of blood. Number two, it occurs in type 2 diabetes mellitus. Number three, ketone bodies is absent here. Now come to pathophysiology. In pathophysiology, we study how osmolarity become increased seriously. How? Question is, how increase blood osmolarity? Blood osmolarity increase by two methods. Number one, by two mechanisms. Number one, due to hyperglycemia, and number two, due to osmotic diuresis. Now, first, hyperglycemia. We already studied in hyperosmolar non-ketotic coma, type 1 diabetes mellitus, type 2 diabetes mellitus, which video already uploaded on my channel. In type 1 diabetes mellitus, there is a absolute insulin absence. There is a absolute insulin absence. Why? Due to autoimmune destruction of pancreatic beta cell. Now, in type 1 diabetes mellitus, due to absence of insulin, lipolysis occur, proteolysis occur, gluconeogenesis occur. But in type 2 diabetes mellitus, there is an impaired insulin secretion, mean small amount of insulin is present, which prevent lipolysis. Therefore, ketone bodies is not present here. But this insulin does not inhibit proteolysis. When proteolysis occur, from protein, glucose is formed, mean when this glucose come to the blood, in result hyperglycemia occur. Number two, when insulin is absent, they cannot move glucose from blood to liver to change into glycogen. Again, hyperglycemia occur. Due to hyperglycemia in the blood solute concentration become increase, in result increase blood osmolarity. Second, osmotic. Second mechanism is osmotic diuresis. We already studied what is osmotic diuresis. Basically, in our kidney proximal convoluted tubule, there is a 100% reabsorption of glucose occur in proximal convoluted tubule. Normally, if we test a normal person urine, there will be 0% glucose. But in diabetes patient, there will be glucose urea. In urine, glucose will be present. Why? Due to osmotic diuresis. When blood glucose concentration is increased than 10 millimole per liter, then in proximal convoluted tubule, the glucose will not be reabsorbed 100% because the proximal convoluted tubule maximum threshold is 10 millimole per liter. Then when glucose are not reabsorbed 100%, they move from proximal convoluted tubule to loop of Henle to distal convoluted tubule. In distal convoluted tubule region, in distal convoluted tubule region, due to glucose inside the nephron tubule, osmolarity increase due to solute concentration due to glucose, and from interstitial fluid the water fluid enter into tubule. Then inside the tubule, due to high osmolarity, the fluid is accumulate and excrete through urine, mean polyuria, polydipsia will occur. Due to polyuria, due to polydipsia, in our body there will be dehydration. Due to dehydration in our body, in blood, due to dehydration, there is a ratio between solute and fluid in our blood. When due to dehydration, body fluid excrete, the body fluid level become low in blood and osmolarity will be high. Why osmolarity will be high? Due to low fluid ratio. Again, when osmolarity is high, then blood osmolarity will be rise. Blood osmolarity increase seriously due to, one is hyperglycemia, number two is osmotic diuresis, because in osmotic diuresis fluid concentration will be low, become low due to dehydration, and due to fluid concentration, decreased fluid concentration, solute concentration will be high and osmolarity will be rise. Due to increased osmolarity, the blood will be thick and in result thrombosis and embolism occur. Therefore, in treatment of hyperosmolar non-ketotic coma, we give insulin to treat hyperglycemia. We give fluids to balance the solute concentration. We give heparin to prevent the thrombus and embolism. This is the pathology of hyperosmolar non-ketotic coma. Now we studied definition, pathophysiology. Now come to the difference between diabetic ketoacidosis and hyperosmolar non-ketotic coma. The first difference is diabetic ketoacidosis occur in type 1 diabetes mellitus and hyperosmolar non-ketotic coma occur in type 2 diabetes mellitus. Number 2, in diabetic ketoacidosis, ketone body present. In hyperosmolar non-ketotic coma, ketone body absent. Why? The reason is third. Because in diabetic ketoacidosis, lipolysis occur because there is an absolute absence of insulin. But in hyperosmolar non-ketotic coma, lipolysis not occur because it occur in type 2 diabetes mellitus, and type 2 diabetes mellitus there is impaired insulin secretion, mean small amount of insulin will be present to inhibit lipolysis. Fourth, fruity breath present. In diabetic ketoacidosis, fruity breath present due to acetone, due to ketone. But in Why? Due to acetone and ketone, due to lipolysis. But in hyperosmolar non-ketotic coma, the fruity breath absent because lipolysis is absent, acetone is absent, ketone is absent. Number fifth difference, blood osmolarity not increase too much. In diabetic ketoacidosis, blood osmolarity increase, but not seriously, but not too much. But in hyperosmolar non-ketotic coma is blood osmolarity increase too much due to hyperglycemia and osmotic diuresis. Sixth difference, in diabetic ketoacidosis, thrombus and embolus absent because blood will not be thick. But in hyperosmolar non-ketotic coma, thrombus and embolus present because blood due to blood thickness. Seventh difference, in investigation of diabetic ketoacidosis, ketone bodies will be present in blood analysis, in urine analysis. But in hyperosmolar non-ketotic coma, in investigation, ketone bodies will be absent. Why? Because lipolysis will be absent. In eighth difference, in treatment of diabetic ketoacidosis, heparin are not used. But in hyperosmolar non-ketotic coma, in treatment, heparin is used. Why? Due to blood thickness, due to thrombus and embolus. Nine difference, definition are different. We already study. The 10th difference is pathophysiology are different. We already study. Now come to similarities. Similarities. Both clinical feature of diabetic ketoacidosis and hyperosmolar non-ketotic coma will be same. This is the second is similarities between diabetic ketoacidosis and hyperosmolar non-ketotic coma. Now, both clinical feature same except fruity smell. Both clinical feature of diabetic ketoacidosis and hyperosmolar non-ketotic coma will be same except fruity breath. Why? Due to absence of acetone. Number two, both investigations are same except absence of ketone body. Both investigations are same of diabetic ketoacidosis and hyperosmolar non-ketotic coma, but in hyperosmolar non-ketotic coma, acetone body will be absent in urine analysis, in blood analysis. Number third, both complications are same except thrombus and embolus. Both diabetic ketoacidosis and hyperosmolar non-ketotic coma complication will be same except thrombus and embolus. Thrombus and embolus are only present in hyperosmolar non-ketotic coma. Why? Due to blood thickness. Fourth similarities, both treatment are same except heparin. Both treatment in diabetic ketoacidosis we already studied. We give insulin and fluid 5% normal saline. Here we also give insulin, fluid, but the additional is heparin. Now our hyperosmolar non-ketotic coma is complete. Now we will study hypoglycemic coma. Now hypoglycemic coma. In hypoglycemic coma, topic outline include definition, causes, clinical feature, investigation, treatment. Now first we should know the normal mechanism of insulin and liver. Normally when we eat a meal, from our blood vessel, glucose carried to liver by insulin. Insulin doing that function, carry glucose from blood vessel to liver to change into glycogen. Now, the liver function is that it change glycogen again into glucose and sent to the blood. This is the function of liver. Then from blood, this glucose is sent to body tissue. But if we take overdose of insulin or other drug, then there is a more transfer of glucose from blood vessel to liver to change it to glycogen. There will be hypoglycemia in blood. Second, if there is a problem in liver diseases, Again, when liver does not change glycogen into glucose, our blood glucose level will be decrease. In the result will be hypoglycemia. Number third, if we take overdose of insulin, if liver normal will change glycogen into glucose, when these glucose reach to blood, again insulin change transfer from blood to liver to change into glycogen. This is a normal mechanism. But now here definition of hypoglycemic coma. What is definition? Hypoglycemic coma is a diabetic coma in which blood glucose level less than 50 milligram per deciliter. This is the definition of hypoglycemic coma. Now causes. Number one, liver disease. If there will be liver disease, the liver does not change glycogen into glucose, then glucose will not reach to blood. The first cause is liver disease. Second is insulin overdose. If we take insulin overdose, the insulin transfer more glucose from blood vessel to liver to change into glycogen. From blood vessel to liver to change into glycogen, there will be hypoglycemia. The third is sulfonylurea overdose, same mechanism of action like insulin. The fourth is malnutrition. If we take that type of nutrition which are carbohydrate deficient, there will be also hypoglycemia. The fifth is fasting. Due to more fasting, there will be hypoglycemia. These are the 5 causes of hypoglycemia. Now come to the clinical feature. There will be 5 clinical features. Number 1, the patient will be weak. Number 2, the patient will be sweaty. Number 3, the patient will be irritable. Number 4, there will be seizure. And number 5, coma. Now come to the investigation. In investigation, we do 2 tests. Number 1, blood glucose test. If blood glucose level less than 50 mg per deciliter, milligram per deciliter, there will be hypoglycemia. Number 2, we do LFT, liver function test for liver diseases. The last is treatment. If treatment will be 2 types. If patient is conscious, then oral sugary juice. If patient is unconscious, then intravenous dextrose will be given. Now, today our topic is complete. In next video, we will be study the remaining diabetic neuropathy and diabetic foot in next third video. Today topic is complete. If you like my video, press the like button, and if you new to my channel, subscribe my channel, press the red subscribe button, and on the all notification in order to you receive my all new video notification. For watching my video, I am very thankful to you. Thank you very much.